All right, so welcome back. Today, we going to talk about how to get services. Hopefully, everybody can see it. So, how to get the service you need. Britt Burner from the Burner Law Group, she's gonna present this topic to us. And I know most of you probably know about PSS already. Just a quick overview about what we do. We are a nonprofit agency that provides services to caregivers and it has formation to strengthen the capacity of older New Yorkers. Um, we are offering a large of a variety of educational training, especially online right now. So that can help the community to stay engaged and connected and find resources. We also have 10 local senior centers. Most of them are closed now, but we're still offering meals to our community, to the client. And also we offer session online, such as educational training, nutrition, exercising online to the members. Our PSS Circle of Care provide free personal support for those caring for somebody who's ill, chronically ill, or has a memory loss issues. We also do have a family grandparent apartment. Is located in the Bronx. It's one of the first in the United States. It's purposely built for grandparent raising grandchildren. Our coming of age program inspiring people 50 plus to live with passion and purpose. So if you some of you has some question, we can use the Q&A box, but also we do have the options. If you want to raise your hand, we can allow you to speak. um, just a quick overview about the census. We know how important it is for our community, so we encourage everybody to go and fill it out online. It's easy. You just log in 2020 census.org. Please count everybody in your house, kids, full children, your grandparents, your mother, your mom, everybody, because we know for the next 10 years it will be able to provide more support and offer hospitals, school, roads, and transportation to the community. Okay. Um, Please, without further ado, Britt, you can try to.
Great, thank you so much. Before we get started today, I just want to take a moment to acknowledge the incredible loss and pain being suffered by individuals, our nation, sorry, and our world. So we could just take a moment of silence. Thank you. I wanted to say that, and I didn't expect to feel so overwhelmed by emotion there. So thank you, everybody. So we are going to get started today. Thank you. Whew. I'm going to share my screen. Okay, great. So my name is Britt Burner, and I am an elder law trust and estates attorney. We have offices on Long Island and in Manhattan, and really here today to just give some education on how we assist people and how people can assist themselves and their loved ones in receiving care services at home. Things have changed a bit with the time of COVID, and I'll try and highlight where I can some things that are special to this circumstance, but most of what I'm discussing is really how we get services for loved ones who need assistance with personal care needs, bathing, dressing, and skilled needs, and how we get those services for them, and the not just financial requirements, but also the level of care that you need to have in order to get these services. So we're talking about home care advocacy, how to get the services you need. I want to really highlight these important documents, and these are planning documents. These are important for everyone to have, and especially as somebody is aging or is in need of additional services and assistance at home, it's important that they have taken the time to designate who it is that they want to assist them in getting those services, and who it is that they want to be the person to step in and help them, especially people with cognitive impairments. You know, as time goes on, they may not be able to make certain decisions on their own. And certainly people with physical impairments may not be able to do the errands and get things done the way they used to. And so taking the time to appoint appropriately and authorize people to assist you is very important. In that, we talk about healthcare proxies. This is the document that says who makes your medical decisions if you can't make them for yourself. And it specifically lists one person. You can have a successor to that initial person. Should list their address, their phone numbers, both home and cell if it's applicable. And importantly, it only has to be witnessed by 2 people. So you don't need to sign this with a doctor. You don't need to sign this with a lawyer. You can actually get it right on the website for the New York State Department of Health. And so the healthcare proxy is a really important form to fill out. If you can also say on that form that you want your agent to be able to make end-of-life decisions for you, artificial nutrition, hydration, that they know your wishes. So this is a really important document that everybody should have, regardless of your age, your diagnosis, or your circumstances. A living will is a document that says what your wishes are. It's usually written generally as a broad statement because it's done in advance of really needing the care. But what it does is it directs your surrogate decision maker under your healthcare proxy, or if you're in a facility and you don't have someone to act as agent on your behalf, it directs them as to what your wishes would be. So it usually says something along the lines of, if I'm in an irreversible state with no hope of recovery, then I would not want to be kept alive by antibiotics, or I would want withdrawn certain treatments like kidney dialysis, cancer treatments, cardiopulmonary resuscitation. You can go through and state what your wishes are if you are in that irreversible state with no reasonable expectation of recovery. And so the living will is a very important document as well. A MOLST form is something that's done when somebody's at a point where they have a diagnosis, a specific diagnosis or prognosis, where they don't believe they have very long to live, and they want to put a much more detailed plan on paper as to what their wishes are, when they should be brought to the hospital, when they shouldn't be brought to the hospital, etc. This is actually a document that is not just signed by the individual, it's actually signed by the physician as well. And so this MOLST form is a Department of Health form. It's on a hot pink piece of paper, and it's actually signed by the individual and the doctor. It is a medical order. Then the power of attorney is talking about finances. So who should make your who should assist you with finances? And you can make it as limiting or as broad as you choose to, and say what powers you want your agent to have. This could become very important as we start to move into the things we're going to be talking about today with your income and your assets when trying to access government services and being able to shift around those pieces of income especially. And so we'll talk about that, but having a power of attorney is incredibly important for having that done. Move on now. Okay, so we're going to talk about Medicare versus Medicaid. A lot of people are very confused because when they come to see us or when we're talking to them about getting home care services through Medicaid, the community Medicaid program, they think that this means they'll no longer have Medicare, they have to change their doctors, they have to change all of their providers, and this is not the case. So it's very important to realize that there are most individuals who are over 65 years old who are on Medicare. If they then need additional services through Medicaid for long-term care services, they actually are what we call dual eligible. So they are eligible for both Medicaid and Medicare, and they receive both. And importantly, Medicaid is the payer of last resort. So they are not going to pay until Medicare has denied for being a service that Medicare doesn't provide or outside of the scope of Medicare services. So for example, doctors, hospitals, rehabilitation in a facility, these are Medicare services, and they continue to be Medicare services even once somebody is also on Medicaid. So it doesn't mean you have to change your doctors, because your doctors are still covered by your Medicare, and you keep that doctor when you keep your Medicare. And the Medicaid is layering another level of insurance on top. When you have a rehab facility, somebody in a rehab facility, again, that is going to be Medicare. Then when somebody is released back home into the community, that's when you start to get into rehab, or the idea is that it's transitioning home from rehab, re-entering into the community, and Medicare will cover a limited amount of services. So for example, it's usually up to 4 hours a day, up to 5 days a week for about a month. And once that is up, or if the person needs additional services in that month, that's when they have to start to think, do I need to be accessing Medicaid as well? Because Medicare is not giving me all of the services I need. The Medicaid, the community Medicaid program for home care, is when somebody needs long-term care Medicaid, meaning that there's an expectation that they will need those services for more than 120 days. And so that's an important thing to realize, that Medicaid is not just going to give you that short-term service like Medicare will. It's going to provide you with a much longer amount of service and even more hours possibly at the time. We talked about doctors also. When you're released from a facility and you do go home, Medicare could give you PT or OT services at home, again, to help you reintroduce to the community. When we talk about financial eligibility for community Medicaid, we have assets and we have income. So on here, we talk about resources. That's what I mean by assets. So I'll start with that. If you're an individual person applying for Medicaid, you will need to have less than $15,750 in your assets. So what does that mean? That is the total of your checking, your savings. Some people have a small life insurance policy that has a cash value. If there is a cash value, that's going to go towards your Medicaid resource level. So you're going to want to think about what to do with that. For example, if somebody has $10,000 in their checking account and a $6,000 cash value in a life insurance, well, now they're over the $15,750 and they're no longer eligible. So that's something to be dealt with. For two persons, if there's a married couple and they're both applying for services through Medicaid, they're allowed to have between them $23,100. And so these are the level of assets you can have. Important to point out is that the asset limits don't include retirement accounts. So if somebody has an IRA, a 401k, a 403b, any of these tax deferred retirement accounts, those are not going to count as a resource for Medicaid eligibility, because that person will be taking distributions from that account, and with an IRA, for example, it would be a required minimum distribution, and that is making it into a stream of income and not a resource. So $15,750 for the single person. And then see there says the monthly, now the income level is monthly, $875 a month. Very few people are able to pay the bills that they have for less than $875 a month. And so it's very important that while this is the Medicaid limit, we're going to talk about how we protect, and for the benefit of the individual, any income that's over that $875 a month. But the official is $875, and again, if two couples are applying, it's $1,284 per month of income. So let's jump right into talking about income. I have an example of somebody with $3,020 worth of income. Now in my head, this is made up of perhaps Social Security, a pension, a required minimum distribution from a retirement account, any interest dividends if they have any stock. For some of our clients that put assets into a trust, that trust might generate income that they're entitled to. Holocaust reparations do not count as income for Medicaid purposes, so that is in a segregated account and does not go into this calculation. When you add up all of the sources of income that somebody has, in my example, this person has $3,020 worth of income. Now they're allowed to have $875, so we're going to subtract that. We're going to subtract $20 for being a DAB. So that's the term that they use for disabled, aged, meaning over 65, and blind. The $20 is a disregard. So the first $20 of income is not counted for those individuals. If you have a Medigap premium, so somebody who has a AARP or United Healthcare, Plan F or a Plan G, whatever plan they have, that they have to pay an insurance premium for this supplemental health insurance, that will get deducted as well as the Part B premium. And on this individual, I put $144.60 because that is the standard amount. Now, those with much higher income are going to pay more out of their Social Security for their Part B premium, but $144.60 is what we see for most people. When I subtract all of those disregards, the excess income that this individual has is $1,680.40. Now, a long time ago, it used to be that you gave over your $1,680.40 to the Medicaid program, and that then they provided you with care. What we are able to do now, and we've been able to do for quite some time now, is take that excess income and meet the spend down by placing that excess income into what we call a pooled income trust, POOLED, pooled income trust. A pooled income trust is where you're going to put this excess income. It is a trust that is a supplemental needs trust under federal law. It is created by a charitable organization, a 501c3. All of the ones in New York State that operate these 501c3s are for the benefit of disabled persons, and they are the administrator of the trust. And they have a segregated account for each person that signs up with them. So in my example, the person would take their $1,680.40 every month, and they would deposit it into their pooled income trust. Now, the pooled income trust has staff, obviously, and they have to run the trust, and so they have fees. So every trust runs a little differently. There's one trust that has a $20 a month fee. There's another that has a sliding scale fee, anywhere between $25 and $200 based on how large the deposit is being made into the trust. And they have various establishment fees or annual fees. And so you'll have to figure out what pooled income trust is right for you or for the person you're caring for. But that pooled income trust will take that fee. And I should also point out that the different trusts also have varying levels of service, and some of them have online platforms, some of them do not. And so you really want to learn what they do. But importantly, once this money goes into the trust and whatever the fee is comes out, the remainder of that income is saved so that the individual can use that income for their benefit while they're alive and still receive those services for Medicaid, even though they technically had excess income. And so the money goes into the trust, and then the bills are paid out of the trust. So I put some examples here of what can be paid. Rent, mortgage, maintenance for anybody who is the beneficiary of the trust. So if my individual had that excess going in, they're then receiving services through Medicaid. They can use the trust to pay these bills. Their utilities, food and household items, clothing. Some of the trusts have a debit type cash card. I actually want to refrain from using the word cash card because the trust can't give cash to an individual. So they can only pay for goods and services. So what would happen is you would send the bill in and they would then pay the bill. For the ones that have cards attached to them, it's almost like a prepaid spending limit on the card that will be set up monthly. And that's going to depend on how large that person's contribution is. But this is a great resource because otherwise somebody would be living on that $875 a month, which might be impossible when you add in their rent and their other expenses. And so this allows them to use all of their income. Now, what's the downside, right? It sounds too good to be true. The downside is that anything that has accumulated over the course of the beneficiary's lifetime will be lost to the trust at their death. So if every month my person has $1,680.40 going into that trust, but they've only used, say, $1,500 a month, then it will begin to accumulate that extra 180 and change. Every month it accumulates, And at their death, whatever had accumulated will go to the trust. So you have the use of it during your lifetime, but it's not to be used as a savings account. Now, some people like to build up money in the trust over a few months because maybe they have property taxes due twice a year and they want to use the trust for that. So it's going to be a very individual conversation as to the best way to use the trust. It's going to depend on what is your excess income, how much is it, and then what are your expenses. Sometimes people have a higher income, you know, $3,020 a month is a fairly high income for somebody in retirement. And someone like this may not have expenses that are as high as what their trust excess is. And in that case, we find other ways for them to buy things that they need, or perhaps to pay monthly towards a prepaid funeral contract to make sure that all of their needs are taken care of. Okay. Now, I'm going to talk about the different types of home care. So there's two main ways that people can apply for home care Medicaid. One is called immediate need. And what it is somebody applies for home care through this immediate need program, and is actually a separate fax number or email address where you can send in applications for this care. You have to use the M11Q form. This is the form that we used years ago in New York City for Medicaid, and now we're using again, and this is how you apply. It's a form that's actually filled out by the doctor of the individual, and that M11Q form is then submitted with the application. It's also submitted with an attestation of need. So someone saying that they're attesting that they need these services, that there's no other way to pay for these services, and that's why they're asking for this expedited process. It is an expedited process. If somebody applies for immediate need Medicaid, their financial determination is dealt with alongside their need for care. And within 7 days, the statute says that the individual has to receive a notice, or a phone call rather, from the local Department of Social Services, which in New York City we refer to as the CASA, C-A-S-A, which is each county's home care program. The CASA will call and say that they want to set up a nursing assessment. While that's being done, HRA in New York City, or the local Department of Social Services, if you're in a different county outside of the 5 boroughs, is going to be determining the financial eligibility of that individual. The nurse will come to the home. They will do a full assessment to determine what level of care that person needs, how many hours a day they need assistance, which is a task-based system. And they will then go back, speak with their supervisor, perhaps with the doctor in the office, and then the doctor of the city, not the individual's doctor. And then they will just decide how many hours of care the person will receive. So for example, they may say that this individual, based on the tasks that they need assistance with, is to receive 10 hours a day of care. They will then automatically assign that person to a licensed home care agency. We call them LICSAs. That home care agency is an agency that has a contract with the city of New York. So you will get assigned to that home care agency. The home care agency will then send in a home health aide to provide those services. I am looking to see if there are any questions. I'm not seeing any, but I'm happy to take questions at the end, but also if you have questions, you can write them into the Q&A box at the bottom, and I'm happy to answer them also as we go through. So when someone, that is the immediate need program. That's how somebody gets care if they need it and they don't have time to wait for the enrollment process that would usually take place. Also, you know, if we have individuals who've transferred sums of money or anything like that, we're not going to be doing an immediate need application. The other way to apply, the regular way, is through MLTC enrollment. So this is managed long-term care. So what has happened is New York State, several years ago, contracted out the Medicaid program to these managed long-term care plans. There are several, some have gone out of the marketplace, they've gone out of business, or they've changed their business model to not be a managed long-term care plan. But MLTCs are the plans that are private. So the state pays the plan pays the home care agency, the plan also pays for all the other Medicaid services that you'll be receiving that we're going to talk about. And so they get what we call a capitated rate. They get one set of, it's approximately $5,000 a month for everyone enrolled, and they have to provide all the care for that person. But it's basically an insurance company. Aetna has a managed long-term care plan. There's one called Elder Plan. There's Centers. There are many different ones. So the question that we have now, somebody asked, is does Medicaid pay for home health aid before they assign the MLTC? So that's a good question. So if we go back to the immediate need program, so the immediate need program is when the city of New York is actually paying for the home health aid services. So under this program, you're not waiting for enrollment in a managed long-term care plan. You're getting those interim services directly from the city's provider, and you will get a home health aide. And then you will be assigned, or you can choose to at which plan to go into. But after you're in this immediate need program, you will transition into a managed long-term care plan. So for people who apply for immediate need, yes, you can get services. If you don't apply for immediate need and you only go directly through MLTC enrollment, then you will not have a home health aide assigned to you until you have been enrolled in the managed long-term care plan. What does that mean? So say somebody applies not through the immediate need program, they send an application to HRA. HRA then returns a financial eligibility. So they have under statute 45 days to determine eligibility. However, in most cases, it's actually 90 days. Because if you are a person with excess income over that $875 a month and you want to use a pooled income trust, you need what's called a disability determination from the state. If you have a disability determination that you need, they have 90 days to come up with that eligibility. So usually we hear from Medicaid within 90 days of submitting the application. I will say that right now we are getting pretty quick responses. I think things are a bit streamlined over at HRA right now, and I'm happy to say that we have not seen a huge delay during COVID in application processing time. So once you have that determination of financial eligibility from HRA, Human Resources Administration, from the City of New York, then you go through what's called a conflict-free evaluation. This is an evaluation where a nurse comes in and does an assessment. They could be several hours long sometimes. And This nurse is there to determine if you are a person who needs more than 120 hours of home care from the Medicaid program and if you're eligible. If you are a person who is eligible, then you will go on to the next step of the process, which is to call the different managed long-term care plans and set up an assessment with the plans so that you can choose which plan you want to use. Many of the people that we advise want to set up 3 plan assessments right at the outset. They do this because each plan sends in a nurse who does an assessment. And while it's called a uniform assessment tool, that nurse may not be coming up with the same amount of hours from plan to plan to plan, because they all have their internal workings. So sometimes the first assessment happens and maybe they've offered 5 hours a day of care. Maybe that individual wants or believes they need more. So then the second plan may offer 8 hours a day. And then perhaps the third plan may offer 12 hours a day. Well, then in that case, they're going to want to determine how many hours of which managed long-term care plan they want to use. The managed long-term care plan that they choose will then have the paperwork signed by the individual or their representative. They will then send that paperwork up to the state, and then that person will be enrolled. The enrollment date is the first of the month after the month in which the paperwork is sent up, as long as the paperwork is sent up by the 20th of the month. If the paperwork is not sent up by the 20th of the month, then in that case, it will be the enrollment in the following month. So right now it's June. If the paperwork's not sent in by June 20th, then the enrollment will not be until August 1 rather than July 1. Managed long-term care pays for, these are just some of the things. There is a more exhaustive list, but some adult daycare programs, hearing aids, eyeglasses, dental services, podiatry, the PERS system, the response system, the button that notifies in case of an emergency, transportation to doctor's appointments, non-emergency transportation. Those are all services that are covered by the program. And we got to the end. I do want to just refer to a few extra things that I want to bring up. That April, the governor and the legislature of New York passed a budget for the upcoming year, and it added in a lot of changes to the home care program. None of these have come into effect yet, and I think we'll probably need to have another webinar to discuss those in the future. But those changes are in relation to, first of all, the services. So now, in order to receive home care services, somebody will need to show that they need assistance with 3 activities of daily living. And if they have a diagnosis of Alzheimer's or dementia, they'll only need to show the need for assistance with 1 activity of daily living. Also very importantly is that if somebody is applying for home care Medicaid, there will now be a 30-month look back. So what that means is that after October 1st of 2020, if you're submitting an application for home care Medicaid, they will go back and look to see if in the 30 months prior to applying for Medicaid, if you transferred any assets out of your name, and the determination will be made if there's a penalty that should be assessed, which will be periods of time that care is not given because of that penalty period for those transfers. I think it's important to say that exactly how the changes are going to be implemented is still to be seen. I was on a call this morning where, as a State Bar Association Elder Law section, we're doing a lot of lobbying with the Department of Health and with the legislature, and there are some bills that have already been proposed in the legislature to clarify some of these changes. So we're really not sure exactly how things are going to apply moving forward in terms of these new changes, but I promise to keep everyone updated. You have my email address here, and I'm happy to add you to our list of documents. We send out newsletters. Right now we're doing them weekly just because we're remote, but do send out newsletters. Usually it's monthly, pre-COVID, and we will be updating people as soon as we know things and as we know things about what's changing with the Medicaid program. That is my presentation for today. I'm happy to answer any additional questions that you have, and I'll just wait a minute and see if there is anything additional.
I think we have one person. I'm just gonna allow her to speak. Hi, Linda. Linda, if you have a question, you can unmute yourself.
Sorry.
But, okay.
Can you hear me now?
Yes.
Hi, how are you?
Good. How are you?
Good, thank you. So I have a question. I don't know if it pertains to this or not, and if you would know this. Once somebody is approved for the Medicaid program, they have an annual evaluation. If there is money that is put into their account, say like a back, unclaimed funds or something that comes along the way, how does that affect their re-enrollment?
The recertification.
Yes, recertification.
Yeah, so you do annually recertify for services with Medicaid, and you have to show financially that you are still eligible. So first of all, when you recertify, you usually are only giving the current month's bank statement. So while it is up to the individual to make sure that they are continually eligible for Medicaid throughout the year, it is actually the proof given is the current month's statement, even though Medicaid could ask for more than that. That being said, depending on where the money came from and what it was, not all, the safest answer is, when in doubt, put it in the pooled income trust and spend it from there. And then you never have to worry that Medicaid could say that this was income that you didn't properly protect. Okay. But income is income in the month received and a resource in the month thereafter. So you just want to make sure that whatever it is, certainly that it doesn't put the individual over the $15,750 in their assets at the end of the month.
Oh, okay. So I'm just going to give you, if I can give you the quick example. So the person that I take care of had a pension check that was put on hold since January because there was paperwork that had to be submitted. It's coming through now, and it should be coming through. And of course, they were just approved in March for February for the Medicaid, but with the MLTC, they're only starting to receive services effective June. So my concern was, now that this money is coming in, is that going to not let them be able to receive the services? But you're saying,
what I would say to do in that case is, this is a pension. So my assumption, tell me if I'm wrong, is this is going to be a monthly payment that's received moving forward, correct?
Well, it's back pay for okay. The pension, yes.
So the back pay I'm not so worried about because they haven't received services, but certainly moving forward, that should be income that's added to the pool trust. Right. And they can either ask for a rebudget so that the budget with Medicaid shows that pension coming in every month, or more likely, especially with the Medicaid, the HRA dealing with COVID and everything, it's something that can be rebudgeted properly at recertification. But you're certainly going to want to be able to show at recertification. What happens is you also have to show a verification of deposit that shows all the deposits made to the pool trust. Right. So that deposit could just show that they did what Medicaid budgeted them for, plus that pension. So Medicaid sees that every month it was properly going into the trust.
Right. Okay. Very good. Thank you so much. I appreciate that.
You're welcome.
There's a question in the Q&A box. Okay. Will we get the presentation via email?
Yeah, I can share that with you if you want.
Yes.
You can send it around.
Yes. Okay, if anybody else have any question, or if you have a question later, you can reach out to Britt. Or if you if you have a question directly for PSS, you can reach out to me. Again, my name is Shayna Jacques. My email is sjacques@pssusa.org. It will be the same email that you receive after registering for the webinar. Again, thank you again, Britt.
Thank you so much.
Thank you for your comment earlier. I got emotional. I have to stop the
Yeah.
video. Thank you, and I appreciate you a lot.
Yeah, thank you. Have a great day, everyone.
Have a great day. Bye-bye.
Bye.